healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Welcome everyone, and thanks for joining us. I'm Stuart Newsom, and today we're discussing mastering LTC pharmacy billing complexity. Now, joining me today is Derek Taylor, who's our Senior Director of Pharmacy Client Services. Derek, I want to welcome you with us. It's great to have you with us as always. Why don't you just tell us a little bit about yourself?
Thanks, Stuart. Yeah, so I'm a long-term care pharmacist that has been working doing remote services for long-term care pharmacies for about 16 years now.
Awesome.
And I oversee Infinix's pharmacy services.
Yes, awesome. It does do a great job at it as well. As y'all will see as we walk through this, some of y'all may already realize this if you're in long-term care pharmacy, the complexity of it. You know, RCM is already complex enough as it is. Any part, it's different components. Long-term care pharmacy is really no different. It's probably more complexity. So today we're going to talk about that complexity, you know, in long-term care pharmacy billing and kind of what makes it unique in that complexity. You know, how patient and payer transitions actually create those operational challenges, and also what organizations can do to improve that billing accuracy and reimbursement performance. And that's what we all want, reimbursement performance. We want that revenue because it's hard to keep that revenue. It's hard to track it down these days. So with that, Derek, you ready to dive in?
Yeah, I'm good to go.
Awesome. So to start, obviously, you know, what makes long-term care pharmacy billing fundamentally different from billing in, say, retail, hospital, or a specialty pharmacy?
Yeah, so long-term care, the population themselves are individuals that are, in nursing homes, assisted livings, places where they reside for a long amount of time. And these patients have unique needs. And so it affects the way that what types of medications, what plans we're using, and how we bill. So the first is that in addition to the traditional private payers and Medicare Part D plans, we see Medicare A patients. Medicare A is a special government paid payment status for patients if they have a temporary illness or injury that needs, hospitalization or rehabilitation. So it's a separate payment status that is only seen in nursing homes and hospitals. We deal with a lot of Medicaid patients, but we have to dispense for some of these patients that are transitioning to Medicaid. So we deal with what's called pending Medicaid, basically patients that will qualify for Medicaid but have not yet received that through their state Medicaid program. And then we deal with hospice patients, and hospices are private entities that manage their own prescription benefits and formularies. So, with those additional payers, that's definitely a complication that comes in the long-term care side. Our patients generally have quite a few medications each. And so that does add to the complexity of the types of rejections we get, or the plans wanting to pay for all of them. And then because these patients are in nursing homes with a lot of medications, we will use unique packaging and dispensing to provide them, weekly or monthly dispensing of medications, or biweekly. And so as a result, what we're dispensing doesn't always match up to the way we have to bill for the insurances. So there's complications on the billing end because of those, the dispensing methods and things that we call cycle when we're dispensing weekly or monthly or biweekly.
Sure. Yeah. So, and I know that's a lot to keep up. You almost have to be like a circus ringleader, I guess, to kind of make sure it all falls into place. But you also mentioned that so much of the complexity comes from patients moving in and out of facilities because, yes, they are long-term facilities and they are mobile. So can you walk us through how these transitions affect billing and reimbursement?
Yeah. So patients, oftentimes they're getting better or they're getting worse, and they're coming in and out of the nursing homes or the assisted livings. So one of the complicated things in our field is the admitting of a patient, what we would call admissions. So when a patient comes to a facility, there's a lot of components of information that we need to set up and have in place in order to dispense. So we have our typical, patient information, our billing, our third-party plans and payment information, guarantor information, but we also have a lot of like clinical stuff that we need to make sure that we have their allergies and diagnosis and different, information on the medical side in the system before we do any dispensing. And the way that admissions works, just by the nature of the beast, is patients oftentimes transition from hospitals to nursing homes or, the facilities. And hospitals start that discharge process in the morning. So each morning they assess patients and see who can we send out and discharge them to the nursing home. And that takes a while. The doctors have to round, they have to, clear all of the paperwork to leave the hospital. And so most admissions into the nursing homes come late afternoon into early evening. And so it's a big bolus, it's a big group that comes in during a limited window. So that really becomes, something that's difficult to manage. These patients, the pharmacy has to deliver medications that night. And some of them come with, antibiotics or pain medications that are urgent. And
Hmm.
so we're stuck with this, trying to handle all of this admission process, but have it done in a timely manner to meet the requirements of getting the patients those urgent meds. And so that really is a big, daily struggle that the long-term care has. A couple other things that you kind of see because of that, transitioning is these patients that are coming in, as I mentioned, Medicare A is based on conditions or events. The number of days that are authorized and when those start and when those end changes, right? Depending on how the patient's doing. And so the pharmacy has to keep track of and bill according to that. And getting that information from the hospital, from the nursing homes, it's hard during these transitions of in and out. And the other is we have patients that are leaving the facility, but for on a temporary discharge, meaning they're going to the hospital overnight for a study, or they're going to, get something done, and where we, have to discharge the patient, but they are coming back. And so we have to, on any discharge, there's this determination of, is this a patient that's coming back to us, in a day or two, and we want to hold that bed, or is this a true discharge that we're gonna, close everything out and push them out of our system? So yeah, the patients transitioning, in and outs of facilities just adds a fun
Wow.
additional steps that we get to manage. So
Well, definitely keeps you on your toes, right?
yeah, for sure.
Well, it keeps them on their toes. It's almost like you got to maybe put a tracker on them. It's like, where are they? And it
For
changes.
sure,
That might be
for sure.
something good to kind of say, hey, wear this wearable. It's going to tell us where you are, where you're
But
checking
yeah,
in.
the
Changes.
nurses, they spend a lot of time just keeping track of them, where they are, where they need to go, which room are they in now, yeah, all that stuff. Yeah,
Yeah, that's a whole coordinator. So yeah,
yeah.
absolutely. And another one of the major challenges, seems to be, determining when a claim should fall under, say, Medicare Part A. Does it go to Part D? Is it Medicaid, or is it out of their pocket, private pay?
Yeah.
So where organizations most often run into trouble with those coverage changes?
Yeah, so this is a major, challenge for long-term care. We are constantly trying to keep track of, what payers are active on a patient and what they qualify for. And there's what we call kind of a hierarchy. There's an order in which, we should be billing this insurance first if it is available. We should be billing this as a secondary insurance. A lot of our clients will have the, complicated, different, they'll have multiple payers, and maintaining the correct payers active in the system in the correct hierarchy or priority of billing is complicated. And so it's really important that we do it, because what happens is, if the pharmacy is going to dispense, right, medications come in, we got to get them out the door. If I have an incorrect or like old payment plan, it might be authorized, that drug might be one that's approved, and I send it, but we get the update that, oh, that patient's no longer covered on that as of yesterday. And so we just
Mhm.
dispense something, and that on their new coverage is not covered. And it's not, it's not the patient's fault. It's not, we can't, blame the insurance. It's our fault that we didn't have the correct one on file. But the result is medications go out the door that we can't then bill for, right? And so we have to write those off. So keeping the proper payment statuses really helps avoid dispensing something that we're not going to be able to recoup. And then within each of these plans, there's not just what they cover, but there's who pays for the copays or non-covered medications. So if you have a patient that does not have financial resources and is Medicaid, for example, the patient, I can't send copays to that patient. The facility is going to have to assume responsibility for that. And so how that's set up in the system is really important, because if I incorrectly assume that I don't have Medicaid on file, for example, and I bill a Medicare plan or a private pay plan or something else, and I dispense something that the patient is not going to be covered, but the facility doesn't approve, right?
Mm-hmm.
We could be stuck, the pharmacy stuck again, having dispensed and not being able to recoup that
Oh,
cost.
wow. Yeah.
So all of this is dependent on communication from the facility. So the nurses are supposed to, they're the ones who are getting the information on like Medicare days, for example, or payment, those kind of things. And every single day they will put into their electronic medical records or EMRs what, they'll adjust the payers. And then we, as a pharmacy, should every day get information as to what, whose plans have changed, who's been adjusted day to day. We call that as part of what we call census. So the
Mm-hmm.
census done in the facility is, where's the patient at? Are they in this facility? Which room are they in? And then, what, based on the payment, is there payer, do we have the correct payer status, or is there a change in payer status? And so trying to manage those in a timely manner and staying on top of them is a big obstacle. Getting accurate information regularly from the facility can be a struggle depending on the
Right.
facility.
Right.
And basically at the end of the month, we get a final census that we have to, go through and do kind of like a big cleanup and make sure that we're catching any that were maybe missed. And so if we don't stay on top of the daily censuses, it's really, our end of month census process takes much longer.
Mm-hmm.
And, we end up having to write off more and more things because we didn't catch them on the front end. We've
Wow.
already sent them and not be able to bill for them.
Wow. Wow. And so, and what intrigues me is when you say, and you've said it twice, the nurses capturing this information and changing the payers. And I'm sure when they became a nurse, they didn't realize they were going to be RCM specialists as well to some degree, right?
Oh, for sure. Right. I mean, this is not, I mean, the nurses do a very good job. I mean, they are stuck with wearing a lot of hats in these nursing
Yeah.
home
Yeah.
facilities.
Obviously. Yeah.
So
Yeah.
for sure. But yes, that is definitely one of the hats they wear. Right.
Awesome. Awesome. So
Yeah.
when billing teams are managing all these moving parts, and yeah, it's a lot of moving parts, and
Yep.
it's like if one thing goes wrong, it's probably going to affect the other. So what kind of errors or delays tend to happen most often, and what impact do they have downstream?
Yeah. So, like I mentioned, if we are not getting routine, accurate information from the nurses, that's, the first major obstacle, right? Because we're not going to be able to update those plans. We're going to have incorrect information in our system, and dispensing is going to keep going on. That's just what happens, right? Meds come in, meds go out. And so getting accurate information like daily, that's one major one. And facilities themselves, some facilities are well staffed and run very organized, and some facilities are understaffed and the nurses are just struggling to get us that information. And
Mm-hmm.
so that is a major obstacle. And then the other is, when we get that information, when we get the daily census, of course, are we staying current on it? Is the pharmacy making sure that all of the changes and updates are all done each, in a timely manner daily? Because if we do that, then obviously, that really keeps us from dispensing medications that aren't going to be covered, and say keeps us from generating the errors that what we would call errors, right?
Right.
Sending medications that we're not going to be able to get paid for.
Right. Right. So yeah, again, my mind is trying to process, all that goes on there and the different layers. And it sounds like you really rely on a lot of good teamwork. I know
Yep.
RCM, any billing cycle, whether it's pharmacy, whether it's any other specialty, requires teamwork, obviously. But this really does, almost accelerates it to that level.
Mhm.
But in a setting that's this specialized? What does a strong operational process look like for keeping billing accurate and keeping it timely and aligned with the patient's current status of current condition?
Yeah, so I mean, it definitely takes a lot of work and intentional, investment in the billing team. So, one of those is, as we mentioned, the struggle with getting the facilities accurate information from those facilities. That is something that the pharmacy really has to invest in, is recognizing the facilities that are not getting us timely census or accurate census, and go over and help through training. Sometimes there's, some technology coordination that we can do to help interface with their EMR to get those, without the nurse having to email them or fax them. But working with the nursing home to have that relationship, helping them understand that if they get us correct information, then we'll be dispensing medications that are covered, and you're not going to have those issues of non-covered medications and or patient. It'll also expedite our ability to dispense. We won't be delaying anything. So kind of an investment in education for those specific facilities that are struggling to get us that accurate information. On the pharmacy side, like working to staff sufficiently to try to put in as many admissions as quickly as possible during that window. If we're able to get the billing team to enter those admissions ahead of dispensing on the front end, have the right payers in at least, then that first batch of meds that goes out that door is going to be paid for, right? We're not, at least that part, we're not going to have to worry about. So definitely investing in the admissions on the front end, during that crunch time, during those windows, with the workflow, figure out how you can maximize your team's efforts on that one. And then I think there's oftentimes, I don't want to say secondary tasks, but tasks that are not quite as urgent. Things like prior authorization management, audits, there's reports that you can run to kind of look through your claims and clean things up. Oftentimes pharmacies that are understaffed or, kind of, overworked, understaffed, whatever you want to put it. Some of these tasks get bumped out or they're not worked regularly. And that really does impact the patient care, and it impacts, how much you're spending time-wise on the month end. So definitely making sure that these secondary tasks, that you're not staffing just to get the meds out the door and, those primary tasks of admission and census, but you're also do have enough bandwidth on your team to manage these secondary tasks before they kind of creep up and bite you.
Yeah, yeah, that makes a lot of sense. And it's almost like help us help you kind of scenario as well. Because it's something like you mentioned, education and telling them, hey, this is what we need goes a long way in making sure that you're getting the right information. It's almost like you have to have a consultant role where you're kind of rolling in, and I mean, they're a client and you're doing the billing work, but you still need information from them. So it's almost like, and you have different personas, for lack of a better word, that you're dealing with in different facilities, all for the same patient. And yeah, that's hair raising.
Yeah. There are long-term care pharmacies that hire staff nurses just as facility liaisons. So they have a long-term care nursing background and are able to go and kind of help nurture that relationship, right? Help the nurses see the way that, it's symbiotic, right? If they take care of us, we can take care of them and everyone's happy. But again, that's hiring another employee to manage that, right? So it's an investment on the pharmacy side to help with that relationship.
Right, right. So as LTC pharmacies look to improve performance, which is what we've really been talking about here, where have you seen the biggest opportunities to create more consistency, perhaps reduce billing friction, and also support better financial outcomes?
So definitely, we've talked about the quality of your census information and the frequency of it. Any pharmacy that has a clean billing office that they're doing well, they have worked through and helped get the facility nurses to get them accurate information and getting there. Some of that includes, for example, the pharmacy information system is what the pharmacy works, dispensing and the clinical stuff, they are billing. The nurses use an EMR, in their nursing homes, and we as a pharmacy can get access to their EMR. So that can be helpful in in having the pharmacy be able to kind of backdoor in and get missing information without having to bother the nurses. So, looking at are we using all of these types of tools, right? Another one is communication with the nursing staff. Inevitably on an admission or, we'll get in there and there'll be missing information. And if we have access to the EMR, oftentimes we can find that information instead of wasting time on a phone call. Phone calls are just huge burdens for the pharmacy, right? Because these nurses are super busy and trying to get them on the phone and have them troubleshoot something. And, things like some of the nursing homes will have software or things where you can do messaging instead of doing phone calls. So, kind of looking at all of those resources on communication with the nursing staff, access to their EMR for missing information, and then of course working with them to get good information. So that's definitely one big one, right?
Mhm.
Staffing, I think in all industries, we've seen that just staffing in general is an obstacle.
Yeah.
Billing members are specialized, they're high cost individuals, and they're in demand, and it's hard sometimes to staff those billing, with good billers. So one of the ways you can tell just in general, if you're wanting to look and see how well a billing office is doing, is to look at their write-offs, right? How much stuff is being dispensed that we've lost that money out the door that's not able to be recouped. And if you have large amounts of write-offs, that's likely indicative of being insufficiently staffed on the billing side. They're not able to get to these things fast enough or to some of these things that catch them from, misdispensing. So, using a lot of, obviously what Infinix does, what my team does is we partner with pharmacies and help provide some of that labor, doing some services in the background, helping them with census, helping them with admissions, those types of things. And so just the bandwidth of your team, making sure that they're sufficiently staffed and recognizing that, yes, it costs money to staff a little more, but look at all that money that's going out the door
Yeah.
that you're losing. And if in most cases, you're going to be still saving money, right? Because then you're going to be collecting all those. You're not going to have those write-offs, and that'll easily offset, adding a little bit additional service support. So,
Right.
yeah, I mean, so that's, and then, in that same vein with regards to staffing, just really making sure that you're not missing a lot of the small stuff. Don't allow yourself to just be busy every day and push out things, that are necessary to collect revenue and stuff. So
Right. Right. Because every little bit matters. Right.
yeah, it all adds
It
up, right.
it all adds up for sure. Well, that's all the questions that I have directly for you, Derek. Then I'm
Okay.
going to kind of move and see if there's any questions from the audience per se. There is one that I notice here that has to do, let me just read it out loud. So
Sure.
you mentioned that new admissions are a struggle, having many arrive all at once, and they are urgent. So
Yeah.
how do LTC pharmacies handle situations where the number of new admissions is very high and they are not able to get them all entered in time to dispense meds quickly? So what I'm hearing here is it's almost
Yeah.
like this mad rush, and there's only
Yes.
so much space to get it all done in, right?
Yes. Yeah. So, and it's weird because it's just such a limited window. It's like, it feels like maybe a 4-hour window. And so something that limited makes it very difficult for pharmacies to staff a full-time employee, right? To target that. So, I mean, the standard, workarounds, not workarounds, but, is first off, make sure that when you're doing all of your billing scheduling, that you are trying to maximize the overlap of shifts in that window. Obviously, the larger your pharmacy is, the more employees you have, the easier it is to do that. But if you're a very small pharmacy with just 1,000 beds or something, you can't bring in 4 guys to work in that window. But if you have a larger staffing, recognize that you can spread out your billing team and make sure that you're trying to maximize it on that end. Some pharmacies, especially with the capabilities of remote entry these days, will contract part-time employees to work just that 3 or 4 hour window, which is really cool if you can find employees that want to do that, because then you're able to get that help in that targeted window. You're not having to try to cover these other hours to spread that out. And pharmacies already do that on the dispensing side. I know a lot of pharmacists that are older and they want to be semi-retired, and they'll work just that crunch time. They come in and just work that little window each day. And, so if you can find that, and most of these processes in most states you can do remotely, which does make it a little bit more attractive to these individuals. It's like, okay, I can work half-time and I can work from home. That's definitely one of them. The other is have solid contingency plans for dispensing without all the information, which is not great. But if you can train, so let's say order entry, right? They're stuck, entering the order and trying to push them out the door. If you have basic rules in place, like, okay, if let's say you can't expect an order entry person to set up a third-party online payer hierarchy appropriately, but you can have them say, okay, is this a Medicare A patient? Is this a Medicaid patient? Or is this maybe a Part D plan, right? And then you can say, okay, based on those, let's just dispense a 3-day supply, or, something where you're getting meds to the patient, but you're at least not risking a 30-day supply, right?
Mm-hmm.
Or if they can identify that it's, Medicaid patient, you can, cross-train your order entry people to at least be like, okay, these are likely going to be covered, or these are likely ones that won't be covered. And so, minimizing the damage that could go out the door before you're able to set those up. And
Sure.
and honestly, most long-term care pharmacies have to do that. It takes a lot of coordination and work to get every admit done on the front end with, their payer stuff in place before they go out the door. Yeah. Anyway, those are my recommendations.
So it sounds like a lot of common sense, right? Just learning the nuances and then just working the system rather than, oh, it's a lot of rules and regulations that we all know and love when it comes to billing for anything in RCM. But yeah, it's kind of I don't want to call them tricks of the trade, but it's almost like you just have to have
Sure.
this knowledge of, the example is, mitigating the damage, or you don't have to dispense a whole 30 days worth, which may be what most insurance companies require. Some even require 90 days, go ahead and dispense 90. So yeah, that makes a lot of sense. Makes a lot of sense.
Yeah. And there are some protections on, a lot of the payers will cover an emergency dispensing supply on a non-covered med for this exact reason, right?
Mhm.
Where there kind of a recognition that there are times when we don't have time to do a full,
Right.
and patient with the urgency. Nursing homes had changed over the last, 30 years from being, very low, what we would call acuity, like how sick the patients are,
Mhm.
to nowadays we have trach patients, that are on ventilators. We have, patients that are on IV feedings and,
Mhm.
much more sick patients that, 30 years ago would be hospital bound. And so because of that, there's more urgency in dispensing. We have to make sure, these are more critical patients. We have to make sure that we get them the medication. So some insurance payers are more forgiving on like that, an emergency dispensing of something that we haven't, that ends up not being covered, but they can give a one-time exception. So kind of looking at those loopholes as well,
Nice, nice, nice. Yeah. So, yeah, that's very helpful. So, someone with a lot of experience, it kind of goes back to that education and really just knowing, the nuances that are involved goes a long way. Wow, this is, yeah, I think I learned quite a bit on this, Derek. So, I really
Oh,
appreciate
okay, good.
you joining us today. So that's all the time that we really have. So I don't see any more questions in the Q&A. I really appreciate you, Derek. Thanks again for coming on board with us today.
Yeah, you're very welcome. Thanks for having me.
And I want to thank everyone else who joined us as well. Always appreciate our audience. You can also visit our website at infinix.com. We have lots of articles, case studies, and even the solutions that you can have and research for all insights for all things RCM.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.